Okay.
Ladies and gentlemen, the webinar is beginning. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. We really appreciate you being here today. This is going to be another in a series of educational webinars, and it's hosted in coordination with Moss Adams, who is an associate member of the Dallas-Fort Worth Hospital Council. They are a long-term member. They are a fully integrated professional services firm. They assist their clients with growing, managing, and protecting their business and making it prosperous. One of their many areas of expertise is healthcare, and they work with many of the world's most innovative healthcare companies and healthcare leaders. Today's topic, strategies to measure and improve emergency department performance and mitigate risk. It's a great topic. We all know the risk that we're dealing with within the hospital setting. And we're going to have a guest speaker today who is a registered nurse, can provide clinical expertise, operational guidance, and she has got experience from across the nation. Her expertise really today is going to focus on the emergency department, and she's going to discuss left without being seen, rates, door to doctor times, and also emergency department boarding hours. We're delighted that Dawn Isaacs, a senior manager and a nursing consultant at Morse Adams, is joining us. She's worked previously, I was just chatting with her, with a large health system in the Midwest. She's received multiple awards from institutions from the Joint Commission, NRC Health, Leapfrog, and from the Centers for Medicare and Medicaid Services. And, I'm hoping that she can explain to me on CMS, if it's Medicare and Medicaid, which M did they leave out? But she'll figure that out for us. Hope we do have a great turnout today that a lot of people signed on. And before we begin, one administrative note, if you have questions, please put them in either the chat box or the question box, and we'll try to answer them before the end of the webinar. But at the end of the webinar, we also will answer questions. And with that, ladies and gentlemen, it's my pleasure to turn this over to Dawn Isaacs. Dawn, thank you for being here.
Well, thank you so much. And yes, I'm glad to be here and definitely speaking about one of my absolute favorite topics, which is the emergency department. I always say when I give this presentation, you're never going to hear the same info twice because I can go all different ways with it. So I'm happy to take questions as they come in or whatever works best for you. I do like to consider myself a bit of an expert in the field, but certainly if there's not something that I can answer, I'll take it away. I love to do some research and then I can definitely get back to you. So let's talk about some of the things that are really bothering us in the emergency department world. COVID, post-COVID, both things, we'll hit on those. But just starting with the overview, long lengths of stay, patients left without being seen, borders, overcrowding. Those are the hot topics in an emergency department. Of course, staffing and things like that. We probably won't get into that so much today, but just talking about some of these burdening things that really are affecting the bottom line, productivity, and things like that. So we're going to dive into some of these things. So I want to make sure that everybody knows that I'm talking about metrics and, how we can improve metrics and things like that. But metrics really means people. So I don't ever want anyone to take away the fact that when we're improving our metrics, what we're really doing is improving quality of care for patients. So whenever I talk about how we want to improve things here or there, yes, you might be able to increase revenue, improve staffing, whatever it may be, but it's all about the patient. And being a nurse, I always want to stay focused on the patient. I'm always a staff advocate as well. So I don't want to ever take the eye off the ball that the reason we do these things, measure these things, is so that we can improve those things. So the current reality, I probably don't have to tell any of you. This slide could go on and on. I just put a few things that are really the key these days. Aging population, we know that's really a key, and of course staffing. Lack of primary care providers or urgent care, that's really impacting the emergency department if they're unable to get into either one of these types of folks. Lack of community resources, especially behavioral health and food insecurity. COVID, we're coming out of the pandemic, but people are still kind of reeling from that. And COVID is still in our emergency departments, which can create some inefficiencies as well. I'm a big proponent of a fast track or a low acuity, so we're going to talk a little bit more about that. And then, of course, staffing shortages and turnover. So we're going to start with one of my favorite things is the patient journey. So we've all been to an emergency department. Even if you weren't there personally to have yourself evaluated, I'm sure you've been there with family. So we're all consumers of the emergency department. We want it to be a smooth process. So when you really think about the emergency department, the arrival process is the key to everything. So we call it the front of the house or the arrival process. So when a patient arrives in the ED, typically what happens is you're registered or triaged. These things can happen at the same time. They can happen separately, but those are things that should happen right away as you walk into the ER. The reason that you're there is called the medical screening exam, or the MSE, as ED folks call it. That's done by a provider or someone that's qualified to perform your medical screening exam in your organization. And then you have your treatment plan, your provider disposition, and then you're admitted or discharged. So that's kind of the very high level basic flow of an emergency department. There are risk areas all throughout these processes. One of the risk areas that I talk about a lot is left without being seen, or now our ED Benchmarking Alliance really categorizes that as left without treatment complete. So left without treatment complete adds elopement and AMA into that. So all along this journey, there are points when a patient can leave. That's one of our risk areas. And then that can also create some EMTALA violations. But it can happen along the journey. And so we want to talk about how we want to try and reduce those risk areas. So the consequences of throughput issues, you've seen it if you've been in an emergency department as a staff member or walking through as an executive or just a consumer yourself. It's all intermixed. We have ED holds or boarders, we're overcrowded, patients are leaving before they're being seen by a provider, or they don't like the treatment, or whatever it may be, but everything is interrelated down there. So what are some ideas we have to improve that? Overcrowding. So what is the root cause of overcrowding? Well, the root cause right now of overcrowding typically is your boarders or your holds. ED holds is what we used to call it. And that is being impacted because your hospital beds are full. So what can we do to improve the overcrowding? Well, you have to come up with some different ideas on how to manage the space that you do have. Some of those things could be making sure that you have inpatient staff to care for your boarders. It could be making sure that your hospitalists are coming down to see your patients, but you really need to take a deep dive into what is causing that. And we'll talk a little bit more about it. I want to talk about length of stay, overall length of stay. So this is a metric that is provided by CMS on the Hospital Compare, used to be the Hospital Compare website, now it's the CMS website. But it does have your overall length of stay listed in for each hospital. That's one metric I like to look at. The metric still leading practice is to have a patient what we call door to disposition or door to dismissal. Still is about 150 minutes leading practice. So that's 2.5 hours. So patients, again, if you're in the leading practice area, are there about 2.5 hours. We see that way bigger times, hundreds of minutes on top of that. So you need to know what your overall length of stay is and know if you're really, in the leading practice category or if you're really long lengths of stay. And then if you do have long lengths of stay, which is what's burdening our emergency department, how do we improve that? Well, one of the things that you also need to dig into is your door to doctor time. So that's where you're going to see patients start to leave. So if you arrive, just like we talked about in that triage process, if you arrive and you're triaged and registered within the first few minutes, really your door to doctor time should also be very short. There's lots of different metrics out there on door to doctor time to also be leading practice, but typically that's within, depending on your organization size, so I can't give you exacts, but I would give you 20 minutes as a general time for a doctor or a provider to see you once you've arrived. So that's a really key metric in improving your length of stay and also decreasing your left without being seen. If your docs are not seeing patients timely, say we're even talking about an hour, that's way too long. So that metric, door to doc, even though it's not publicly reported, that is something that you would have to dig out of your computer system, would be something that you would want to look at, especially if your left without being seen rates are high. So if a patient is not being evaluated timely, that's when you start to see people leave. So do you know these timestamps? Does your director of nursing or the medical director of the ER, can they tell you what those timestamps are? Can they tell you what your length of stay is, what your door to doc time is? And what are your goals? How do we work together to improve those things? So length of stay would be a key metric. If I was a consultant coming into your emergency department, I would want to know those few things. Now, again, the length of stay I can find off the CMS webpage. Now, it's a year in the rears typically, but it will still give me some sort of idea on where you're sitting. Patient satisfaction, staff satisfaction, of course, that can cause throughput issues. At times, staff don't have a sense of urgency of moving patients along. You might have an emergency department full of travelers, which, nothing against travelers. A lot of times these are highly experienced nurses, but don't necessarily have the buy-in for your community, for your organization, things like that. Patient satisfaction, if they're not being treated timely, you have to deal with grievances and things like that. So these are all just keys that you want to start to dig into a little bit as you're looking at your throughput issues. So left without being seen, that's the second metric that is publicly reported that I always take a look at. So left without being seen, again, I talked about left without treatment complete. Those are two different metrics. Left without being seen is part of the left without treatment complete total metric. And again, elopements and AMAs against medical advice also fall into the left without treatment complete. These metrics, you want them to be as low as possible, which means your patients are not leaving once they arrive. So what is your issue if you have one with left without being seen? Perhaps you don't. Perhaps your metric is 1%, 2%. We wouldn't want to see it much higher than that. But is the root cause that your length of stay is too long? Is the root cause that your first evaluation time by a provider is too long? So how does that impact your bottom line? And I do have a calculator I can show you if you are an organization that has a really high left without being seen. I can show you how the patients walking out the door can really impact. So if you're talking about 10 patients a day walking out, you really don't want to see that. Patients, if they did need to be admitted, they're going to come back at some point and they're going to be sicker than they were hours before, maybe a day before, whatever have you. Or if they were more of a fast track patient or a low acuity patient, perhaps they took their dollars and went to an urgent care to be treated. So I will give you the calculator on how you could potentially take a look at that and see if this is something that is really impacting your bottom line. So again, the front of the house arrival process, full of risk. Each stage should be done timely, so really decrease that patient of left without being seen. And the overcrowding, if everything's done timely, the overcrowding will decrease as well. So I want to talk a little bit about triage. Triage is something that's pretty near and dear to my heart. Nurses are typically the ones that sit out in triage. They have to have special training for that. So we want to talk about being bottlenecked at triage. So when you walk through your emergency department or you've been to an emergency department, what does your actual triage process look like? Are you standing in line just to be triaged? If so, that's what you would consider a bottleneck. And what are we going to do about this bottleneck? Is there something additional that we can do? Well, I like to talk about the Chick-fil-A method. So I don't know about you, but we frequent Chick-fil-A here in town. And Chick-fil-A does something different than most fast food restaurants. And so what they do is they bring their window people, where you're placing your order, out to the cars, and they have multiple people. So it's kind of the same thing as triage. If you have one person sitting in a triage window and you have a line of people backed up to get into your ER, that is a true bottleneck. You have to bring people out to get moved through quickly. It's a risk area out there. You could have patients collapsing if they're sick, they're waiting in line, things like that. So there should be a very clear plan at triage as patients are arriving on what you do when they arrive. And if you start to have this bottleneck, perhaps it's the Chick-fil-A method. You bring people out. Perhaps it's making sure that the registrar who's working out there with the RN is, helping lay eyes on and doing what they can within their span of control and things like that. So the bottleneck at triage is something that is a huge risk point. And if your emergency department does that, I really encourage you to take a deeper dive at the triage process. Quick registration, like I said, I mentioned that that happens either in tandem or it might be done by the nurse. If for some reason nursing isn't allowed to quick reg a patient, this is usually done by patient access. Take a closer look at that. We shouldn't have to have a patient go through two separate patient access, then nursing if you have a really busy ER and people are starting to pile up. This should be very, very quick and easy. If a patient's been in your system before, a lot of times that patient can pull right up. You have to confirm them, things like that. So ensure that the quick reg process with triage is happening very, very timely. Use of standard orders or provider in triage. I'm going to skip that one because I'm going to come back to it here in another slide. But this is where it gets pretty clinical, but super important to make sure that standing orders or provider in triage is something that occurs when your ER starts to build up through the day. Hallway beds versus waiting room. I'm going to skip that and come back to that. And then long door to doc times, we've talked a little bit about that. Typically, patients should be seen pretty quickly within arrival. They're there to see the doctor. So you got to make sure, how do we get the doc up there and seen timely? So here's some recommendations for the triage process. Again, this is something that I take very serious. The triage process by a nurse is basically quantifying if a patient is sick or not sick. So does the patient look bad, having a medical emergency, or are they here for a sore throat, ear pain, tooth pain, med refill, those types of things. Those things have to be separated very quickly up front. So this should only be done by a few well-trained RNs. This isn't something that everybody should do. You shouldn't have your new nurse doing it. It should be somebody who's experienced in the emergency department, able to make that quick assessment, that critical first look, and get the patients triaged appropriately. Formulate a plan when a bottleneck occurs. We talked about that. The Chick-fil-A method. What is it? Do we bring the charge nurse out? Do we pull another nurse out? Do we have someone on call that can come in? What is it? Whatever the plan might be for your organization, you have to have one, because standing in line at triage is not the answer. It's a huge risk of patients having a medical emergency out there or walking away once they've arrived at your department, which again could be an EMTALA violation. Now, you do have to give staff nurses a little bit of education because ambulance patients arrive in the back. And so when they do arrive in the back, the nurse that's caring for the patient still has to have some formal education to understand how that patient should be triaged. And for those that don't truly understand a full triage process, we call most of the nationally, we use what's called ESI, Emergency Severity Index. The other triage process is the Canadian process, which I haven't seen in a long time. But ESI is 1 through 5. 1 is your most critical patient. Usually some sort of resuscitation is happening as the patient is arriving, whether it's a trauma, a code blue, a stroke, perhaps, maybe a STEMI. That would be all of your ESI 1s. And then your 5s are the sore throats, the ear pains, things like that. So as soon as a nurse triages a patient, typically your ER providers in the back can see that a ESI 1 or 2 has arrived, and then they really create their who they're going to see next, their plan based on ESI. So it's super important that nurses have the proper training to triage all patients. I typically recommend outsourcing the education unless you have a really strong education program at your organization. Triage First, ENA, those folks have true triage programs that you can send people through online and get that extra education. There's a pretty good section on EMTALA as well. Your triage nurses should really be very aware of EMTALA. And then you should audit your triage nurses for accuracy, timeliness, and educate annually. Are they able to do triage accurate? And it needs to be timely. We say that triage should not last. I give them 3 minutes at most, and that's probably giving them a minute too long. Triage should be super quick. So in the organization, if you have all these questions that you want the nurse to ask at triage, you need to get away from that. Triage nurses should only be asking pertinent questions that's going to affect their care while they're there. You know, the travel screening questions and things like that, those really aren't pertinent. So you have to be careful with a lot of folks throughout the organization thinking that the triage nurse should ask these questions. It should be a very quick process. The nurses in the back can handle the rest of the questions after we've determined if the patient is sick or not sick. So again, triage and quick reg, just to talk another minute about that, should be done in tandem or in quick succession. So typically in a big ER, there's 2 folks up there. You have your RN and your patient access registrar. They can work together. They can do one after the other, but it has to be quick. Everything should be done quickly up front. Again, risk up there, patients are sick, etc. And remember, I always like to talk to nurses when I'm actually in the department. Triage is actually a process, not a place. So that is something for every nurse, every director of nursing in an ER to remember. You know, your triage window, yes, most of them sit in a window. Yes, most of them sit up front, but triage is not a place. Triage is a process. So more about the PIT model or standard orders. These are 2 more diving in clinically into how you can improve your length of stay, you're left without being seen. So nursing standing orders, they are dropped or put in by a nurse after the nurse has triaged the patient. So it might be done by the triage nurse, just depends on your organization. You just heard me talk about how this needs to be super quick. So it just depends on if that triage nurse has time to drop an order or not. But nursing standing orders, for example, might be during flu season. You activate your flu protocol, your influenza protocol. So say in November, as the flu season rises and, you know, it's active in your community, you put forward the nursing standard order set that when a patient arrives with A, B, and C criteria, that the nurse can go ahead and drop the flu swab. That go ahead and activates that to get done. So potentially by the time the patient even sees the provider in the back, perhaps the lab order is done and boom, we know the patient has influenza. So nursing standard orders can be very, very critical in improving your length of stay, but standing orders can get very messy, especially when it comes to compliance with the Joint Commission. So those things, although I am an advocate for them, they have to be written very well. They have to be approved by usually your med exec team. and your nurses have to be very clear on what they're ordering and why. Other very obvious standing orders would be like an EKG when a patient arrives with chest pain. But you can do much more than that. You can do urine samples, pregnancy tests. There's a litany of standing orders you can put in place in your organization. And again, this is the nurse making after some criteria are met, they put the order in. So the patient is getting this treatment done prior to seeing the provider. Again, you have to be careful with it, but it is very helpful. Provider and triage, the PIT method. This is either a big success in your organization or usually a complete failure. Providers have to have buy-in into this, but those that do it and do it well have amazing length of stay times. So one of the organizations I used to work at, as soon as the ER hit, however many patients, maybe all the beds were full, or maybe we had so many arrivals within a certain amount of time, the providers, what we would say in the back, one provider would come up and work with the nurse in triage. So once the patient had been triaged, if they were sick, not sick on that acuity score, the provider would actually have a space up front and get to see the patient and drop some orders right away. So maybe a patient comes in with abdominal pain, which is a super common ailment to come into the emergency department for. Abdominal pain is vague. It obviously requires workup. It could be super critical. It could be something not as critical. So a provider up in triage, when the patient arrives, could order your ultrasound, your UA, and whatever else they might order. Once they've done their medical screening exam, remember that's why the patient's there. They're there to get that medical screening exam. That provider up in triage can drop some of those orders after their evaluation, and the patient can start. Maybe they're stable enough to go back out to your waiting room because they're just waiting on an ultrasound, a urine test, lab, and can sit in your waiting room and not even occupy a bed while they're undergoing some of their tests. And then when there's room in the back and a provider can pick up that patient, again, they might have many of their tests resulted, and that really keeps the flow moving very, very well. So the PIT method works well when it works well. The big thing is that to really get the providers buy-in, of course, you have to have nurse and provider collaboration. And then, just have to really work together on that. The one, I would say, pitfall to that is at times, if you put a provider up front, if the providers aren't on the same page or work well enough together, the provider in the pit might put some orders in that the provider in the back, once they pick up the patient, would have never wanted. Or they might say, well, he didn't order XYZ, and so it still slows the process down. So there certainly is some cons to the pit model if you don't have a really cohesive group, but I've seen it work very, very well. So that would be something I would always recommend in an organization. However, if it doesn't have the right collaboration between nursing and providers, it might be something that we would have to, put to the back burner and go down different avenues. Put patients in hallway beds instead of the waiting room. So hallway beds in the waiting room, those are two theories, phenomenons, whatever you want to call them, that usually a nursing director or whoever it may be has very strong feelings about one way or the other. In today's COVID world, boarding world, you really have to use your hallways. And that is, you're in compliance when you use your hallways. There is some nuances to that. So you'd certainly want to talk to your organization's safety officer, but hallway beds are really a must anymore, just because there's not enough actual patient beds for all the patients that are there. So just like I described before, if you have a patient that arrived and your organization is busy enough that you have a provider in triage, and the provider did order some tests. Again, if the patient is stable enough, they've been through triage, so the nurse has done vitals, the provider has performed a medical screening exam, not all patients need a bed. So you can put patients in chairs, you can line the chairs up in the hallways, you could actually carve out a part of your waiting room and send the patient back to the waiting room, especially if they don't need a monitor right away or an IV, things like that. They just need some of those lab and radiology things to get started. So you really have to use all of your space that you have available. You have to be creative with it. You have to talk to your staff and providers on different ways to do that. You certainly have to talk to radiology and lab to make sure that they're going to come out and see your patients in these places like the hallway, the waiting room. But my theory always was that the waiting room is a very, very unsafe place for most patients. There's typically not enough eyes on the patients. Depending on the size, there could be tons of people in there. And a lot of times there's family. So you could get confused on who the patient is, especially if everybody's dressed like typically they are in a waiting room. It's not like the patient has a gown on. So the waiting room can be very, very unsafe. There's people that walk in the doorway. And I always teach the triage nurses that you should know every patient that walks in your waiting room. Because if the patient does walk in, doesn't actually approach the triage desk, let's say they go to your restroom in your waiting room before they come to the triage desk and collapse, you're at a really big risk there. So you have to be very careful with congestion in your waiting room. And I know that the hallways in the back can be very congested as well, but there's lots of people back there with eyes on. So to me, it is a safer place than your waiting room. So just another piece of an assessment that I would encourage that you look at if your emergency department is really, really busy. So a low acuity strategy model or fast track. So a lot of people say they have a fast track, but I would urge you to take a closer look at your fast track if you do have one. And if you don't have one, I would encourage you to also really look at what it would take to do this. So again, this is your nurse up front, your triage nurse, patient sick or not sick. So if you have those level 4s and 5s, I mentioned the sore throats, ear pains, etc. They need to go into really kind of a whole nother section of your ER and have staff care for them that are just really focused on the low acuity patient. If you are intermixing these throughout your waiting room, throughout your department, your overall length of stay is probably high for that reason. Because a nurse or a provider, either one, is not going to pay attention or be as focused on a patient that has ear pain versus the patient that is coming in with, severe shortness of breath and things like that. So those low acuity patients get pushed to the back burner, and that really, really increases your length of stay. And when you increase your length of stay, you're taking up space in the ER, but you also need more staff for them. So if a patient should be in and out, but they're not, it's a slow process because perhaps the nurse is caught up with a sicker patient, you really need more staff. So a lot of times if I can come into an organization and take a look, you're not, really executing it the way it could or should be done, you could decrease some of your staff by becoming more efficient in these things. And a lot of times I don't want staff to think, oh gosh, we're here to cut jobs or things like that. Most ERs have enough open positions. You could say, hey, we've executed this. We've decreased our time so much. Now we don't need, 2 more nurses to come in the afternoon because we're so much more efficient. So let's take a look at our arrival patterns and maybe we can make some changes there. So this is a quick calculator. You can find this. I put the source at the bottom. I always go to the ACEP website. It's the American College of Emergency Physicians, and there's a left without being seen calculator there. So if you know some of your numbers, you can put them in to be more exact, but at the very top, I put ED visits of 40,000. I just put in a few numbers. And then you can put in how many were admitted for the year. You can look back if you have this real data, how many were discharged, the revenue for a discharged patient and an admitted patient. Again, your finance department could probably give that to you. I was conservative on the admitted part by 10,000, and then discharged patient, I put 500. So just putting some guesses in there, but you could certainly become more accurate. And then you want to put your change in left without being seen. So let's say your left without being seen rate right now in your organization is 5%. and you want it under 2. That's really the goal. But let's say you just want to have an improvement of 2%. You put that in there. These other percentages are kind of standard percentages that you put in, unless you're an organization that goes on high diversion. So diversion is when you close your ER. You might make that decision. Your ambulance service might make that decision. Perhaps you're an organization who doesn't even know what I'm talking about because you never go on diversion. But if you do go on diversion, which means you're closed to ambulances, if you clean up your left without being seen, your length of stay, you can quote unquote open your doors to more ambulances, and then of course, more patients, which is good from a bottom line perspective. So you can see at the bottom, if you increase on just 40,000 patients, you increase your left without being seen by 2%, that's a $1 million revenue enhancement. Again, this is on the ACEP website. So talking a little bit about the treatment process. So one of the things in the emergency department you have to really take into consideration is lab and radiology. So anytime a patient is an acuity level 3, 2, or 1, which are they're sicker patients, your abdominal pains, etc., we know they're going to have lab and radiology. So how long does it take for those tests to come back? So that would be a really good question. Perhaps you already know the answer because you work really cohesively with lab and rad. But turnaround times for both of these should be something that you're collaborating with, you're improving on if they're not meeting the mark. There is standard benchmarks for these as well. We know that CT utilization is high these days. It's at least around 30% per 100. So are you waiting a long time for your CT results? Is it a problem at night when nobody's reading it or what have you? So that is something that as you look through your length of stay, lab and rad become key to collaboration and making sure that this is happening timely. And then some treatment plans could have been ordered before screening. We talked about that. That is your provider in triage or the nurse dropping some standing orders up front. So again, that's going to get the process going even quicker if those things are being done sooner in the process. And then boarding and ED holds. We can talk a little bit about that. Unfortunately, there's not like a cure-all for that one that's really quick and easy. So again, talked about reviewing lab and rad times, treatment plans, boarding and holds. So let's talk about that. So does your organization have an organizational and ED specific surge plan? So, and I'm not talking about a disaster. I'm not talking about a bus crash in your city. I'm talking about just a classic, you've had multiple arrivals at one time. Perhaps you have multiple boarders in your department on top of multiple arrivals, and you've just had it kind of blow up, so to speak, in the last hour. So you really need both. You need the ED specific plan. Maybe the ED specific plan is as simple as the PIT model. When this happens, we bring a provider out. When this happens, we use hallway beds. So that's examples of the ED specific surge plan. An organizational specific surge plan is NEDOCS, the National Emergency Department Overcrowding Score. Some of you may have heard of that. Some of you may have not. So this is something that can be automated within your system. I know that Epic and Cerner both automate this number, and it's a number that pops up on the screen. Typically, everyone in the ER or wherever you want it to be, it will show up. So it's basically green, yellow, red, black type of thing, however you build it. But when you hit that red or black because you're super busy or you have super critical patients, everybody in the organization knows it. This isn't just an ED problem. So what happens when you've hit the red or black and the whole organization needs to chip in? Maybe it's lab and radiology each send another personnel to the department to check in with the charge nurse. Or one of the key items that I've seen done a lot of times is when a patient is going up to a nursing unit, instead of the ER taking the patient up, when you're in the red, the nurse from the unit has to come down and get the patient. That saves a lot of time and your ER staff aren't leaving the department. So those are some things that you can put in place with an organizational surge plan, and specifically using the NEDOCs. And that's talking a little bit about those nursing units. But I would also review your patient admission percentage. Do you have docs that are, admit way too many patients? Do you already know that's a problem? There is a national standard for that. Usually it sits right around 20% of ER patients are admitted. So where do your docs lie? Are you admitting too many patients that it's actually causing an issue on your inpatient units, which of course backlogs into the emergency department? Again, another data element you can use to really dive into your boarding problem. This is an example of the NEDOCs calculator here off to the side. It's normal, busy, overcrowded, severe, etc. So again, your electronic system can do this for you. There is NEDOCs is something that you can look up as well. It's on Google, but you can do it manually as well if you need to. But it is something that does work well, unless you're a emergency department that is always just off the charts, because then it's like having alarm fatigue. You're constantly in the red and black, and then nobody even pays attention anymore. So that would be the one downfall to the calculator if you're really always busy. Some just other recommendations I like to throw out there. You can implement a provider scorecard as well to provide specific feedback. Perhaps you do that. You really need to talk about the left without being seen. If you have is the rates higher when a certain provider's on because they're too slow, they don't care? What is it that's really causing patients to leave? Maybe there's no one specific thing, but once again, you can track that. If we have on the day shift, we have 5% of our patients that leave without being seen. Again, why is that? Are we understaffed? Is it the same doc, etc.? So again, more data elements you can look at to be able to really pinpoint some of your issues. You can again put in the door to doc time, the door to decision. So when are they making that decision to either discharge the patient or admit the patient? You can put patient satisfaction on their scorecard, etc. And again, just understanding the current metrics in your department. You might have a leadership team that really doesn't have these metrics available to them. And even if they do, perhaps they don't have the time or the understanding of how to move these metrics. So, we're always happy to help with things like that. But pulling some of these metrics that I mentioned today would be a good start to really being able to define what the issues are. And again, analyzing your left without being seen. You don't want patients leaving. Once they arrive, they can go to your neighboring hospital, make a complaint, etc. CMS can come in and fine you for EMTALA. There's a few different reasons that patients can be there can be an EMTALA violation, but typically the patient is there for a medical screening exam by a provider. So if you have long time element from arrival to provider, they might complain about that, which could start the investigation for EMTALA. Boarders and productivity. So those of you that have lots of boarders, there is ED Benchmarking Alliance and the Emergency Nurses Association have both put out current methodology for boarders. So a lot of people now are being able to take a deeper dive into this, but years past, sometimes organizations just simply made up how you would quote unquote account for a boarder in your emergency department. So there are several methods. Again, you can look these up. I put them here so that you can take a look at them. But you should be able to measure your productivity and benchmark for the next year, even perhaps during your budgeting process, to see if your boarders are really impacting. Because of course, if there's inpatients sitting downstairs, that's going to impact your productivity. So take a deeper dive into these methods and make sure that you are using that appropriately, especially if you have a significant amount of boarders. This is just a quick example. Now, when you get these slides, you might take a closer look. It might be hard to see now, but in this first box, it showed the total productive. This was an example of an organization that I worked at. And so when I first, when I consulted at, so when I first took a look at their productivity and their visits, they told me that they had 154,000 visits a year. But when I received their data, I saw that they only had about 90,000 visits a year. So they were calculating for their borders, but they weren't using a current methodology. So it made them look like they were running super, super productive because they thought they made it look like they had more patients. But when you use the methods that I put in the last slide, you could use a couple of the different methods. We actually found that their hours per patient visit was off the charts, higher than anybody else. Normally you want to run ER, just hours per patient visits, run around 3. They were pushing 8. So, they were 2 or 3 times more. And then when I was on site, taking a deeper dive into their department, the staff were tripping on each other. It was total chaos down there. So it was, you could really see, yeah, you're trying to send help to the department, which is super busy, but there's really no great flows, there's no efficiencies, and then your hours are just being sucked away down there. So again, just an example, when you take a closer look, you can see that the new methodology that's out would really impact some of your bottom line. So this is just kind of off the beaten path of what I talked about previously, but other support, I have to always mention security. The emergency departments are generally an unsafe environment for staff to be in. Patients are, with the behavioral health issues, with unfortunately a lot of drugs on the streets, things like that. Security really needs to be visible in your department, especially if you're in a city where maybe there's a lot of gangs, drugs, what have you. But I know that a security officer is typically one of the very first people, besides Reg and your triage nurse, I want to see when I walk into your department. I'm sure your staff would appreciate that as well. Clinical decision support, this is a term that goes around that's talked about more because what is your electronic system offering the providers when you're entering orders? So is your clinical decision support a nuisance or is it really helping? So make sure that you're using those appropriately and reviewing pop-ups and things like that might burden your teams. And telehealth, I'm sure telehealth is something that everybody's looking at these days. How does that work? Does that make things smoother in your department, et cetera? So I've talked a lot during this time. I'm checking my time. If I was to ever come in and help you out, the key things I want to look at is data. And so I would encourage you to look at your data. I talked about some of the metrics that I would encourage you to pull from the get-go. That's what you would need to do to start making some changes. I always come in and do observations. I like to take the time to sit in triage, sit in your waiting room, walk through your charge nurse, see what kind of things they're doing, talk to your medical staff, things like that. So those are the high level things that we start to do if we ever come in and work with you on site. Implementation's a whole nother phase of things that we can do to help you. We might be able to come in and do an assessment and tell you your pain points. We could also stay and help you with those changes, knowing that change can be super challenging. And so we're happy to do that as well. This is one of the things we really like to do. Perhaps your manager of your department or your medical director, whoever already does this, but we always want to realign staffing to demand. So you should be looking at your department. When I was a manager of the department, I always pulled this every 6 months. How is my whale changing? So this is arrivals. This is the pattern of arrivals for patients. So as you can see at midnight, that's the 0. There's still a few patients, but as the morning creeps on, that's your slowest time. That should be when you don't have as much staff. And then as the day kicks up, how does your staffing kick up with that? So you want to make sure that is aligned. That is something that we would definitely do if we came in and took a look at the department. I think we talked through this enough, talking about throughput and charge nurse, triage. Your charge nurse and triage nurses are the two that really kind of run the ship, so to speak. So those are again, observations I like to make when I'm there. Quality initiatives, always happy to do that. Sepsis, stroke, cardiac, trauma, and again, security, behavioral health. Those are all key things. I think I'm going to end with that, just on how we can help. Talked a lot about metrics today and what we can do to improve our emergency department. Again, knowing that these are always patients that we're talking about. Whenever we're improving time and things like that, it's improving patient care. So I want to wrap that up. I'm happy to talk more about anything that I maybe didn't talk enough about, or questions that you have that's come up along the way.
Yeah, Dawn, this is Steve. One comment that one of our participants put in the chat, the Canadian equivalent to ESI is CTAS, Canadian Triage Acuity Scale. So I was going to point that out. And I do have some questions. Some people had submitted some questions prior to this. One was a lot of boarding problems seem to occur due to lack of beds to admit patients. And then we had one in the chat. What strategies have you seen work well to address the boarding problem we have?
Okay, so boarding is really two problems. Boarding is an inpatient problem. So you need to take a look at your inpatients. Do you have a long length of stay for your inpatients? So if your average length of stay is 5, but it really should be 3 in your organization, what are you doing on an inpatient side to improve that? So that's one thing. And that's a whole nother animal in itself, because then you're talking about your social work, care management, you're talking about beds outside your hospital, what kind of long-term care beds do you have, things like that. So that's an animal separately, but definitely needs to be looked at, because if your long length of stay in the inpatient world will definitely affect your ER. The other thing that is really important to look at is your admission rates. Are your docs over admitting patients? We've seen that. I was in an organization that their admission rate was 39%, almost double the national average. And so, maybe it's the area in which they live, but take a deeper dive into that. And then again, maybe you need a physician scorecard. Is it 1 or 2 physicians that are, need some education or whatever it may be? But if your admission rates are off the chart and you're admitting way too many patients, I would take a look at that. And then there's some things you can do in the department, in the ER. So say you have 20 boarders on average every day. So I would recommend that inpatient staff care for those folks. That's easier said than done, because it's like, well, where does the inpatient staff come from? Maybe you have a float pool. Maybe when you have travelers, the travelers actually go into the float pool that support the ER. But ER staff should not be caring for boarders. And I know in a lot of organizations they do. So those are some things that can just help with some of the initial ideas to help with that.
A follow-up question I'll ask you, because I was in a meeting this morning at one of our member hospitals, and they certainly understood the boarding issue, and you've touched on it well, but behavioral health, and when people come in with mental health issues, especially children and adolescents that appear, sometimes the boarding becomes even more complicated. Do you have any thoughts about that?
My only real thoughts are that, unfortunately, that is really a statewide epidemic, so to speak. So when I see that patients are stuck from a mental health perspective in an ER, which is common, sadly, it's because there's nowhere for them to go. So then you have to ask yourself, how active are we on a legislative level in our state to make sure that we have the behavioral health support that we need? Some states are way more supportive than others and have places for patients to go. Is that a quick answer? No. You're talking about something potentially that could last years, but the behavioral health crisis has got to be looked at a state level, and you have to have active folks really advocating for that.
Certainly understand that and agree. A question that was submitted, are there other models that pit that you're aware of to other than PIT, that you're aware of to expedite the triage process?
Standing orders would be the other one. The other thing I would really, some people call things like the vertical model. I touched on that a little bit. Just remember, not all your patients need to lay down, and actually very few patients need to lay down. So to expedite things, unless you're a sick patient, you can go back to another area. You can go sit in the radiology waiting room. No, I'm making that up. Don't do that. But you can go back to other areas to make sure that the tests can be performed once they're ordered. So don't keep a patient in the waiting room when a chest x-ray has been ordered just because the patient hasn't been roomed. So those would be ways to continue to expedite. Any more in emergency department and the room, I mean, there's only so many rooms and there's usually a lot more patients. So do not wait to room patients to get their treatment plan going.
Here's another question. In some of the hospitals you visited with and consulted, do hospitals that you've seen require the emergency department to triage the patient prior to dropping protocol orders?
Yes, triage really needs to happen almost. Again, I talked about the Chick-fil-A method. Triage needs to happen very quickly as the patient arrives, and then their treatment plan can happen. It might be from the standing orders or what have you, but the patient has to be labeled sick, not sick, for the provider to be able to make choices on where they go next for seeing patients. So yes, triage is very instrumental.
Here's another question. Do you find internal waiting spaces helps or hurts throughput? Example, resulting in a pending area.
I have typically found those are helpful. That is really the trend is, internal waiting rooms. Again, it's those low acuity patients, those not sick patients that you can almost start to visualize that they're there to see, you're there to see your PCP. I come into an area, I see them, they order tests, I go to an internal waiting room where the radiologist picks me up for a chest x-ray, etc. So again, those spaces are really results pending, things like that are a way to keep the treatment going without occupying a room.
Here's one also that's really just kind of asking your opinion. Once you truly feel you have no additional space in the ED, what do you recommend? And the reason for the question, we just moved into a new ED and are already out of space.
I know that is hard. I mean, there does come a time where there is absolutely no space. One of the things that you have to take a dive into is what's your inpatient space look like? I do like to tour the command center, the bed control transfer center, whatever your organization calls it. I like to go visit them and observe them as well. Are there delays there? Are there inpatient beds ready and available, but the nurse upstairs is busy or at lunch, or maybe your housekeeping service isn't turning over beds quick enough upstairs? So yes, you run out of space, but there's got to be space somewhere that can be more efficient, typically. But again, your waiting room starts to pile up. Your ambulances may need to go on diversion, things like that. But I would highly recommend that you develop some sort of fast track to clean up that killer time that's just not necessary, and then that will provide you more space because your patients are there less.
You mentioned what's going on the inpatient side, and there was a question about, based on your experience, do you have any helpful hints or strategies on how you gain inpatient support when you're boarding patients?
Yeah. Well, it all comes down to relationships, in my opinion. What type of relationship does perhaps your emergency department nursing director or manager have with the units upstairs? Do they do you have that relationship where you know that there's a sense of urgency upstairs too on a dismissed patient, so the provider rounded at 8 a.m., but the patient that's being dismissed is still here at 4 p.m. Like, are your peers helping you out? So just trying to develop that relationship and make sure that they recognize your sense of urgency down in the ER by them helping you.
I think we have one final question, and I know you've touched on this, but what are some common standing orders that you truly recommend to improve throughput? And do you also suggest, and I know you touched on this earlier, a chief complaint-based standing order?
Yeah. I don't know if I could even go into that without a lot of specifics, but we had 10 when I was the nursing director of our ER. I mentioned some of them. Your flu swabs during flu time, perhaps even it's still COVID today. Your RSV in babies. It's a urinalysis in some folks, but again, that has to be kind of a limited criteria. You should always have your EKG. You might have a dry CT for stroke patients, depending on if you're a stroke area. So those are just some basic ideas. Wrist X-ray on kids. Those are big. Got lots of kiddos that break their wrist. A nurse should, pretty typically be able to put that order in, get that kiddo in and out.
One thing, and this is just a pure question from me. Prior to me being here at the hospital council, I worked 35 years in a hospital on the administrative side, not clinical like you. When you change these kind of protocols and when you try to improve efficiencies and when you go out and do consulting engagements, as you know, we all know and want to comply totally with EMTALA. Should any of these changes be viewed by legal counsel?
Yeah, certainly you could. Again, I think that just depends on your trust in the legal counsel, because perhaps like in my organization, I was more of the expert in EMTALA than my legal counsel, just because I lived it and studied it. And your organization, a lot of times your legal counsel has, just like anybody, they have other things that it's a priority, but somebody should be your EMTALA expert, no matter, might be your medical provider in the ER. But you can always run it by them, but they might not understand. So you might run into that barrier.
Right, good point. While we were talking, 2 more questions came in. What are your thoughts on hallway boarding upstairs?
Ooh, that's a tough one. I don't know. I haven't seen it done well. I have not seen it done well. And most organizations do not do it, mostly because your regulatory issues. The ERs are built for safety and I shouldn't say that. Just from a compliance perspective, the ER doesn't max out. But up in the inpatient areas, from a regulatory perspective, you can't have a cart here and you can't have a cart there. And it just gets super tricky. You take a patient up there, the next thing you know, you got to use the restroom. And where are they going to go to the restroom? And, there's just, it gets icky. But if somebody's done it well, I would love to see it, but I have not seen it done well. So I'm not really a huge proponent in it. I would be more likely to see how we can get the inpatient staff to pull their patients out, things like that. See bed control, how quickly are we turning around beds, and help in that way.
Here's an interesting question too, and I'm confident you have an answer for it. Can you speak to virtual care in the ED environment? Have you seen this strategy effectively implemented anywhere?
Well, I guess it depends on if you mean by virtual care, are you talking about stroke telemedicine specifically, like specific care, behavioral health, things like that? Those are common nowadays to do, a behavioral health consult. If you have, a psychiatrist that's not going to come into your ER, but you have a PD overdose. So that's absolutely, but I don't know if you're talking about virtual care for every patient that comes in. You certainly couldn't do it, I don't think, if you're a super busy ER, just because pulling up the screens and the IT process can sometimes slow you down. But neurologists in the middle of the night, that's common anymore to do telemedicine, to call them up and do a stroke and give your alteplase or whatever. Again, behavioral health, super common. Laboring patients, high risk. I put that in my slide. That's also common because you can't get those specialists in, especially in the middle of the night. It's better just to do telemedicine.
Right. I think it's a good answer, and I think you're right. It's kind of specific to what you're dealing with. Well, I don't see any other pending questions, but Dawn, this has been excellent. We can't thank you enough. Great presentation and great questions from the participants. So we'll give you a chance for any closing thoughts, and then we'll close out this webinar.
No, I guess my only closing thoughts are, it's super important to support your community. I know, again, I talked about metrics. Again, metrics are people. Improving all of this improves the quality of lives in your community. Your emergency department folks, I really encourage them also to be active in the community. Make sure that they're very aware of your ambulance services, diversion. How does that look? Are you getting your ambulances back out on the street timely, not sucking them in, taking 30 minutes to bring a patient? So just make sure that, again, the patient is the forefront of what we do. Make sure that we're being able to give them the quality care that everyone deserves when they come in.
Well, Dawn, thank you. We really appreciate this excellent webinar, and we're going to conclude at this time, but I know Chris Wilson is going to send out to all the people that registered your presentation and your contact information. So on behalf of everyone, thank you very much.
Thank you. Have a great day. Please reach out with any questions.
Okay. Bye-bye.
Bye-bye.